So we've pretty much went through the major drug classes for diabetes. There's a few other drugs that don't really kind of fit into a specific category. So we just loosely define them as other oral medications or other medications for diabetes. Culcivalum is a bile acid sequestrant, and it has a very small reduction in A1C, less than 0.5%. Ramipriptine we'll talk about in other disease states, but it's a dopamine agonist of all things, and it'll offer modest reductions, or I'm sorry, minor reductions. It's 0.1 to 0.4% reductions in A1C. Lots of adverse effects. Amylin is probably more beneficial than the other two. Basically, it activates amylin receptors to decrease glucagon secretion and delay the gastric emptying time. It will also increase satiety. Typically, you administer this subcutaneously, so this is injected 3 times a day with meals. Both type 1 and type 2 patients that are on insulin can use amylin, but you can actually produce a severe hypoglycemia outcome when co-administered with insulin, and so it's kind of dangerous, but it does offer some therapeutic success in a small subset of patients. Other medications, we can move to the kidney, and we can interfere with the sodium glucose cotransporter on the proximal tubule, which really accounts for about 90% of the total glucose reabsorption. So by blocking this cotransporter with either of these two drugs, we can see a reduction in glucose levels. But of course, we haven't really done the kidney yet, so we'll just kind of briefly talk about it in passing. One thing I do want to point out is that when we talk about all of these drugs, like how do they fit in a scheme or in a treatment paradigm? So this is kind of where I'm going to leave you off right here, and then Dr. Prasad is going to kind of put the nail in the coffin, so to speak, in terms of how to go through all these drugs. But from a general kind of standpoint, when you've got a newly diagnosed patient with type 2 diabetes, the first thing you should be offering them is weight loss or exercise program and metformin. Okay, and then within a few months, look at A1C, look at the patient's journal or log of blood glucose readings, and then if metformin by itself, with diet and exercise, isn't producing the optimal glucose targets, then you can add another agent. And then if that doesn't work after several months, of course you're increasing the dose of metformin as well, you can add another 2 agents. And if those 2 agents plus metformin don't work, then you can add maybe an insulin. Okay, and so you can kind of rank these drugs, and this is kind of how they're ranked right here. Metformin, followed by sulfonylureas, followed by the DPP-4 inhibitors, and then the next category can be probably either or TZDs or GLP-1 agonists. And so in all of these drug lectures, we talked about, well, which drug offers the most potent reduction in A1C? Okay, and so metformin, and so the previous list kind of mirrors the list of drugs in terms of their ability to reduce A1C, with metformin being the strongest, sulfonylureas being the second, and the TZDs and glidines essentially being the third. You can kind of see the drugs being moved around as you go into 3rd, 4th, 5th, and 6th, and so forth. Okay, and so as I end this lecture, so how do you put all this together? Well, a good source of diabetes management is really the American Diabetic Association's yearly publication called the Standards of Care, and the link is right there. You can click on it. It's actually the 2018 link. It was just published in mid to late January of this year. And it's the current kind of guideline for managing diabetes. And this is what it looks like. Here's the cover page. I just copied and pasted it. Okay. So Dr. Prasad-Reddy is going to give you a little bit of a overview in terms of kind of going through these guidelines. And I really like how they're laid out. And she can kind of put her own clinical spin on them. And so there might be a little overlap in terms of a slide or two, but just listen to her lecture, and hopefully it'll put everything into a greater perspective for you. Okay? And if you have any questions, please email me, and if I can't answer them, I will definitely be forwarding to Dr. Reddy. Thank you.